All right, good afternoon and welcome. Thank you for coming this afternoon. I'm Dr. Leah Shanley. I'm the Co-Executive Director of the Southeast Data Innovation Hub here at the University of North Carolina, Chapel Hill at the Renaissance Computing Institute. For those of you in the room, we ask that you turn off your phones. For those of you who are participating on Webex, we ask that you mute your mics until the question and answer session starts, because we don't want dogs barking and babies crying in the background. For those of you who tweet, oops, back to that slide. For those of you who tweet, we ask that you tweet with hashtag SBDH17 for South Big Data Hub 17. We're also across the hubs using BD Hubs and, of course, Data Science, because we both have not only the South Big Data Hub here today, but we also have the Midwest representatives from the Midwest Big Data Hub, but we also hope that the broader audience is watching. So welcome to the South Big Data Roundtable series. This is the third in our series, as we're just getting launched this last year. It's an ongoing series where we're focusing on the priority research challenges and potential solutions in data science and analytics. So welcome to the South Hub and the West Hub. Today's discussion will focus on translational data analytics for environmental health, and we have a very distinguished panel. We have our Deputy Director of the Renaissance Computing Institute, Dr. Ashok Krishnamurthy, and 4 distinguished panelists, 2 of whom are here in the room and 2 are participating on Webex. On Webex, we have Dr. Andy May, who is an assistant professor in the Department of Civil, Environmental, and Geodetic Engineering in the College of Engineering at Ohio State University. Go Ohio State. His main research focus is on atmospheric impacts of combustion emissions. Dr. Ayaz Hyder is the assistant professor in the Division of Environmental Health Sciences in the College of Public Health and is affiliated faculty in translational data analytics at Ohio State. His research focuses on understanding the role of multiple determinants of human health, operating at multiple levels of organization. Dr. Peden, who is here to my left, is a distinguished professor of pediatrics, senior associate dean for translational research, the associate chair for research in medicine, the chief of the Division of Allergy, Immunology, and Rheumatology, as well as the director of the Center for Environmental Medicine, Asthma and Lung Biology, and I don't know how you find the time. His primary research focuses on the impact of environmental agents and pollutants on respiratory and systematic inflammation and physiology. And then we have Dr. Paul Kizakevich. Okay. He's a senior, can you say that louder so everyone hears it?
Kizakevich.
Kizakevich. He's a senior research engineer in the bioinformatics program at RTI International. He directs the Personal Health Informatics Toolkit team in the Research Computing Division at RTI. He's developed smartphone-based systems for daily monitoring of health, activity, diet, location, substance use, and environmental conditions, and is currently exploring their use in precision medicine and personalized health intervention. So with that, I'd like to hand things over to Ashok to moderate. Our panelists will get us started with 5-minute opening remarks, followed by some moderated questions that Ashok will lead, and then we will open it up to roundtable discussion, not just here in the room, but also online. So Stephanie, you're the one monitoring Twitter, I presume? Yeah. Great. So Stephanie will be following. If you use the hashtag SBDH17, she'll see your questions, and we will intermittently try to ask some of the panelists when we get to that portion. So with that, I hand it over to Ashok.
Thank you, Leah. Thank you, everybody. Welcome to Leah, did you say the third roundtable?
That's correct.
For the South BD Hub. Honored to be the moderator for this distinguished panel. And as Leah mentioned, we are going to be talking about environmental health and sensors, and the format, as Leah mentioned, is going to be 5 minutes of conversation or presentation by each of the panelists, and then we'll have questions. Off camera, we have somebody who's going to be the stickler for the time, and will give us when the time is 5 minutes up. We thought about what's the right order to have our panelists talk, and I think that the first person to talk is going to be Andy?
Yep.
So, Andy, you are now in charge. I don't know if you have is there a presentation that Andy is doing?
Yes.
No, no slides.
No slides. Okay. All right, Andy, all yours.
Well, thanks for the introduction. So Ayaz and I are going to go in tandem here, describing a project that we have through NSF, co-funded by environmental engineering as well as the US. So we are you guys hearing?
Yeah.
I'm hearing like,
We're adjusting the volume, and unfortunately, it's a little bit touchy. So you're either too loud or too soft, but I think we got it solved now.
okay. All right, so we've established a collaborative partnership with the local high school, Hilliard-Davidson High School, located just outside Columbus, to utilize some low-cost air quality sensors to monitor traffic-related air pollution. So here we're focusing on carbon monoxide, ozone, nitrogen dioxide, and particulate matter. And so the focus of doing these measurements within microenvironments across the school district to try and capture these environments where the students, spend the majority of their day. And so this is an integrated approach that ranges from sensing to data visualization, which is something that Ayaz will get more into in a little bit. So briefly, just describing the sensors. We bought some off-the-shelf sensors for carbon monoxide. We have an ozone plus NO2 sensor, and just an NO2 sensor. We got these from AlphaSense. And we have a Shinye PM sensor, along with a temperature relative humidity sensor, and a single board computer to sort of tie everything together and do data acquisition. One thing that's worth noting is that we're not really focused on improving the technology or developing calibration methods. There are lots of other people that are working on these, and they're doing a very good job. And just another sort of caveat with this work is that we're not really targeting regulatory equivalent data, but really just data that can provide information to local residents regarding the air they're breathing. And so the role of the citizen scientist then is, we're essentially their client, but also their vendor. So they're working for us. We're providing everything for them. So what they're working through, they're putting all the electronics together based on the template that we provided for them. That we developed at another project, and they're actively involved with their district administration regarding the placement of these sensors on school buildings. And so currently, we have all these sensors back at OSU in our lab for calibration, and the plan is that we'll do the calibrations in OSU, take them back out to the field, and deploy them, and start collecting the data, hopefully by early next month. And that might have been shorter than 5 minutes, but that's probably good. There's more time for questions. But I think that's a good time to segue to Ayaz, since now we can acquire data, and he'll talk a little bit about what we can do with the data.
Sure.
That's great.
Right,
Thank you, Andy. And Ayaz, over to you.
All right, thank you. So my role in this is that when we first got started in this, Andy knows the engineering and I know the public health, and also a little bit about handling the data. And in public health, we're not typically trained to do that. We're typically trained to do public health, to do epidemiology really well. And so we have the collaboration that we have is really one that I'm really excited about as just the words data analytics starts to be used outside of a biostats department within schools and colleges of public health. So in that context, what I'm interested in is how do we make these data that are being collected by the sensors useful. There was a editorial some time ago about consequential environmental epidemiology, which built off of the idea of consequential epidemiology from Sandra Glea. And the inspiration is really coming from there is how do we, in public health, make these data matter. So we are doing this work in Hilliard, where I actually live, and my kids go to school, and we go to the parks, and we go around. And one thing about Hilliard that's really interesting is this north-south gradient in terms of socioeconomic status. Another interesting thing about Hilliard from an exposure assessment perspective is that it north-south, it goes along a major highway. And some of the schools are actually located at almost on the same road, but at different distances away from the highway. For those of you who are coming from the exposure science world, these are some of the challenges that have been dealt with when creating exposure surfaces. And so we're hoping to use these sensors to come up with a better understanding of what are the curves, for example, for exposure based on distance from a highway, and then along different land use patterns as well. On top of that, we're really interested in working with the students to figure out how do we make this data relevant to their own learning, and that's where the citizen science components comes in, and working with teachers to understand that, but also to educate the current students about the importance of data analytics and then what they can do with this in public health after they graduate. Another application that we're thinking about is partnering up with hospitals and the healthcare providers, but also local public health departments to deploy these sensors around their neighborhoods. There are different healthcare financing models out there, and some of them actually incentivize improvements in the community, which in turn reduce many of the measures that are used for quality improvement within hospitals. And so we're trying to work with some of the partners that we have here in Columbus to see if we can deploy these sensors and give them a better idea of environmental health disparities in the populations that they're serving. And the data visualization aspect, I'll just touch on that briefly and then I'll end, is we're working on a website that is going to be taking the data from the Raspberry Pi, sending it to the cloud, and then visualizing it through ShinyR web applications. For those of you who are familiar with ShinyR, it's an open source software. And so we're trying to make this as open source as possible. And this website, the flexibility that I think ShinyR gives us is that we can develop modules that can be relevant to the end user. So if we're in the school system, we can create a website using the same data, but displaying different types of graphs, maybe just a simple time series plot. Whereas in a hospital setting, we might be able to create more spatial forecasting models that look at where are the increased risk of an asthma exacerbation, for example, or a cardiovascular outcome related to air pollution on high air pollution days, based on the real-time data as it's coming in. And so you can see potentially applications of this integrating with the screen which the physician is looking at with their patient, or kiosks within a hospital or a public health department, individuals who are coming and using services in those areas to say, oh, I didn't realize the air pollution was so bad, or they can go online and see, oh, at a very local level, what's the air pollution and what mitigation strategies can I take to avoid maybe certain areas, or maybe not send the kids out that day especially if they're asthmatics to that park, but maybe we can go a bit further away where these sensors that are so localized are telling us.
Ayaz, let's get back to that. Thank you very much. I want to now move on to Peden and hear what he thinks about on a more individual level as a practicing immunologist and allergist.
Well, thank you. I appreciate the opportunity to participate in the roundtable. My clinical specialties are in pediatrics and allergy and immunology. So the diseases I personally take care of are asthma, any number of allergic diseases, and also diseases where people are more prone to increased infection, the clinical immunology aspect of that. The underpinnings of that specialty deal with inflammation, and that's a I'll come back to that in a minute. But as a physician, what we need is a better understanding of how environmental factors, both traditional air pollutants like particles and ozone, impact human health, whether they directly cause problems or whether they prime somebody or set them up so that with a second hit, they are likely to have a clinical event. So so those are bits of information we need. As a doc, I can tell you that what I'm probably not going to be able to do is sit in front of a computer screen and assimilate a vast array of information, try to distill that into actionable information. And I'm a research doc, which means most of my time is spent doing research. If I were actually in clinic every day of the week during flu season, I'll probably be asked to see anywhere from 20 to 50 patients a day. So I'm not going to. So that's where the data analytics come in. What I need is algorithmic approaches so that I get a ping that says enough events have happened with this person. You might want to pay attention to that. So I think that's in terms from a user perspective, I think that's going to be important. And I think for many of our patients who are the ultimate users, that's going to be important. So separating signal from noise from the user perspective, I realize that a lot of the noise is necessary noise and it's probably music to the data people. But to me, I need whole notes, not 16th notes. So that's going to be an important factor. Because of my research interest, though, I would point out that part of the data analytics is really having an appreciation for what the epidemiology tells us about relationship with pollutants and environmental factors and health. It's also going to be important for us to understand the timing of those things. There are the effects of chronic persistent exposure to pollutants that have long-term effects. So an example of that would be kids growing up in Los Angeles in, say, polluted areas. It's very clear that with chronic exposure to air pollutants, your lung growth is simply less. Your forced vital capacity or your forced respiratory volume at 1 second will be less if you grew up in a place that was more polluted than not. However, an episode of asthma or an episode of bronchitis will occur acutely. The trick is in the timing. It's not going to be immediately after the exposure for most people. It's going to be within 8 to 24 to 48 hours later. So understanding that, so that if I knew, for instance, that my patient had been exposed and I got a ping, I might be more prone to say you might want to use some additional corticosteroid now because did you realize that you were exposed based on either where GIS information, just knowing regionally where they were, or if they're actually wearing a personal monitor. The personal monitoring part of this, I think, is really important because there are elements of both the indoor and the outdoor environment that are important, and you can know regionally what happens, but unless you can calculate the activity level of a person, where they are, and if you're going to recommend changes to their housing, that might be important. You need to know what the dynamics of their housing are. So if they have a lot of particles, a HEPA filtration unit might actually be as good an investment as more chronic controller medications, but you need to know that. If there are smokers in the home and that directly impacts the particle distribution, that's important to know. And that's visceral information that you can show somebody. But so it's going to be it's an exciting opportunity, but it also represents significant logistical challenges. So I think that we have to put all that together. I've been fortunate that I'm involved My true day job is to see how air pollutants affect people doing artificial experimental exposures, and we use that to screen interventions that they might use. But that work has led me to two major collaborations. One is with an NSF-funded nanotechnology center where they're inventing both environmental and physiologic sensors that can be self-powered. So their trick is that they're making them self-powered, so looking at that technology and then all the data stuff. And the other one, I'm working with folks here at RENCI, which is another NIH project in which we hope to incorporate environmental measures into health analytics. And I echo the enthusiasm about marrying this up with clinical data sets, and we can talk about that more as the roundtable continues. Thanks very much for this.
Very good. Thank you. So we started off talking about technology, and then we went through two applications, public health and individual health, and we're going back to technology and have Paul tell us about mobile health platforms and what's happening in that space.
Well, let me also thank you for the opportunity to be here and enjoy this conversation. As a biomedical engineer, my interest has been most of my career in developing technologies that would serve the research and medical communities for new types of data collection, new types of analytics. And as far back as unbelievably 30 years ago, I think it was 1979, there was the first personal monitoring conference held at the Carolina Inn. And we presented a paper on the idea of cardiac monitoring for getting activity data that might be related to air exposures. Because we were doing a lot of work with the facility that Dave's at over in the EPA here on the campus during that era. And so that led to, about 10 years ago, developing a platform for collecting human data that would modify exposures, like diet for dietary exposures, data related to exercise, with actigraphy before it was built into the devices, to information about form-based data about other types of exposures, and also including information about the environmental conditions of somebody in the moment. EMA data on, I'm near a fireplace, my neighbor's burning wood, or whatever it may be, some kind of observation about the environmental state that they were in at that moment. That further led to our interest in mobile health as the new technology came about. And again, so we developed this platform, which is ostensibly for mobile health, but really a very comprehensive data collection platform for getting data and deriving actionable information in real time, so you can process that data and provide people useful information, whether it's for health intervention or maybe basically an environmental intervention, which leads to a health intervention. And so I have a few slides to mention what that platform is. This is kind of a top level view, and we use kind of a SOAP note model, subjective and objective measurements. Always had the desire for objective sensor measurements when possible. As an engineer, I really like that. So we have four main components to the system. We have instrumentation for taking in data. We have in the green area, we have a concept of a virtual advisor. This is really the analytical part that would take evidence-based models or rules or processes to look at the data that are coming in periodically and come up with evidence-based recommendations of what to do. And that may lead to certain activities, which could be health intervention, self-help interventions, or advisories, or go shut the windows because your neighbor is burning wood and you get a lot of particulates coming in. To a system which is unusual for a mobile health system, which is scheduling and data management. So we've built in essentially a scheduling algorithm, which is not unlike Outlook, where you can say, I want to take this measurement every day at 2 o'clock in the afternoon. And that data will be automatically fed to the virtual advisory. And that could be a sensor measurement going on in the background. So that's built in this framework schema. It's going to be the next slide. So this shows the application of this framework and the range of capabilities we've built into here for a project we were doing for the military, which involves, again, subjective assessments, sensor-based data, and a variety of feedbacks and interactive activities, mainly aimed at reducing symptoms of post-traumatic stress. And this mobile health app is aimed at persons who have subclinical post-traumatic stress. They don't have PTSD, they've not been diagnosed, but they might use this app, and then the app might help them determine whether or not they should go seek more help, but also give them like stress relaxation tools and other things they can do. But the same platform can be reused as we've done in the past for environmental data collection, contextual information, sensor-based data, and then providing real-time and near-time feedback for their use. And the next slide illustrates something that we're implementing right now. Literally have the first version of this working about 8 o'clock this morning, where the concept of sensor processing, most people think of sensors as something you're going to put out here, just going to collect data, we're simply going to take the data. But whether it's a sensor or some other data stream, these are all time series data. And to an engineer, time series data means data I want to process and do something else with. So we've now incorporated into our platform a schema where we can have modules for data processing that are linked together by XML descriptors to take sensor data, process data, and derive new measurements in real time. And this could either be for relatively modest speed, like physiological data. We're taking pulse wave data, processing it, and coming up with heart rate variability information. Or it could be time series data taken once a day. But that data may lead to some N-of-1 processing to say, okay, this person, is FEV1 now is going off the charts. He needs to do something. So this is an exciting new aspect of what we're doing is this type of data processing.
Okay. Thanks. So, I think very interesting remarks by all of the four panelists. I wanted to sort of lead off with a couple of related questions. The first one, this is really for both Andy and Ayaz, and the question is, where does the sensor technology go? Where do you see, Andy, the sensor technology is eventually going, particularly if you look at it as a personal sensor? And then the question for Ayaz would be, how does that affect how you look at it from a public health perspective? If you can indeed, if you're saturated with these sensors, so all this data is available all the time, what does that imply for public health?
So I guess I'll preface my statement with I'm not somebody that works in sensor development. So maybe a little out of tune with where the technology is going specifically. I mean, I'd like to think that it's going somewhere that we could get to more widespread use of personal environmental sensors, something somebody can carry around. But to me, there's really two issues. And the first is really cost. So we're using these quote-unquote low-cost sensors, but each of our individual gas sensors costs roughly $70. So multiply that by 3, add in our Raspberry Pi computer, everything else, and we're talking about a package that's around $750. So it's still maybe not really towards that personal level that I think we want something to be much cheaper than that. And so kind of sort of along those lines, I'll use an anecdote of an in-home carbon monoxide sensor that I'm sure many of us have in our homes. These cost around $30, and that's the complete package compared to the $70 just for our CO sensor. But really, the trade-off here is sort of how well the sensor works at sort of lower levels of the pollution. So I think the when we have in our home, the lower detection limit is around 1 or maybe 10 parts per million. But really, we're not seeing, I don't think we're really seeing 1, let alone 10 parts per million in many ambient environments anymore. So the sort of trade-off of the cost and how well the sensor works. And the second issue to me is miniaturization. So right now our package is roughly shoebox size, and if we're talking about something that somebody's going to potentially carry around or wear, we want something much smaller, because right now I think we're a little too clunky to be portable. Getting back to the image we just saw of somebody wearing these sensors around, I think it's almost like they would need to wear a backpack or something with our current setup. And so I think there's some people working on improving sensor technologies. So again, I'd like to think that we're getting to something more realistic for personal use or for mobile use in the near future, but we'll see what happens, I guess.
Right. So for the question that was asked, what are the implications for public health? And I think the implications for public health are going to have to be with the role of public health. Public health is primarily concerned with the health of populations, the health of vulnerable populations, whether it's based on some demographic variable or it's a spatial context. And I think you can measure everything about everyone, but so what? How do we actually use that information? And I think we're still in public health, in epidemiology, trying to figure that out. We know that every mouse and how much time a mouse hovered over a button, Amazon can use that information to design better buttons, maybe, or change the user experience of an individual. But I think in public health, we have to be concerned with, well, what does this mean for this population? So I think that for now, the role that I see for public health and the implications that I see are primarily in terms of what they can change, what they can modify, sitting with whatever regulatory powers that they have, but also the education of the public about the impact of air pollution on certain populations. And then creating educational tools that are accessible, that are relevant, that are can actually be understood by basically anybody. So I think it's probably not a very good answer, but I think we're still trying to figure this out. So yeah.
Thank you. Probably not a very good question. Maybe that's why. Getting back to, I have a question for both Dave and Paul. Again, I am very intrigued by this notion of personal environmental sensors. And let's say you do have that. You mentioned how that could possibly help you to help your patient directly. Where do you see? How far do you see that scenario that you cannot? Because right now, it's very. I believe it's very hard to get that information into an electronic health record that may exist for the patient, so that it comes to you, or should that not go to the health record at all, but come directly to you?
Well, first of all, we can have a large discussion about the regulatory and the ethical issues of environmental data from various sources being entered directly into the healthcare record, how people access the healthcare record, and how people use it. But before we go there, I actually think that one of the things that that we need to keep in mind is what will people use, how much do they want to be monitored, who wants to do the monitoring, and also are any devices we make things that even if people wish to have monitors, they're actually going to wear or they're actually going to use. And I think that's a big problem. Another factor is, do you need 24/7 surveillance of specific things? For some diseases you might. If you've got someone with seizure disorder and you have a monitor that can do EEG and you see them in a pre-seizure state, digitally, that you kind of have to know about. You need event monitoring. On the other hand, for people with chronic inflammatory disorders where things change over hours or days, you may need much less frequent data assessments, and so part of it is going to be the scenario that you look at. I personally think that it will be a combination of personal monitors and people who are motivated to use them. If you're a bad asthmatic, you may well want that kind of monitoring. But I think that's going to be coupled with marrying that with GIS data, with regional monitoring. And some of these personal monitors may well become the regional monitor for that person's house, whether they wear it all the time or not. And I think we're going to have to factor in human behavior and desire with that. But I'm guessing that the 15-year-old guy with asthma may or may not want to wear his personal monitor all the time. It's just kind of like he probably doesn't want that thing you put in your car so that you know where he's driving around and what his speed is at too. So I think the human factors of this are all going to have to be put in there. I do think that there are two ways to think about personal monitoring. One is for sentinel diseases that we're pretty confident have an environmental perspective or target. So asthma, cardiovascular disease, congestive heart failure, those are, at least for acute events, there's pretty good data for that. There's also going to be knowing what we don't know. There are any number of disorders that are almost certainly impacted by environment very directly that we won't begin to know that until we start looking at those things. And that's where I come back to having a basis in inflammation. Inflammation is basically that branch of the immune response that responds to your environment, whether it's internal or external. So understanding what disorders have an immunologic basis or neurological basis, which is the other way that the body senses data, will be helpful. So I'll be quiet for a minute.
Okay. So the question for Paul is really around, it looks like what you have may be the beginning, or maybe it is a platform to sort of create the kind of feedback that Dave's talking about, where you can help somebody get some advice on what to do if they have disorders.
It's designed for that sort of thing, and it's based upon our history and experience and planning to get to this point. So I think that is possible. I do want to comment one thing on what he said, and he may respond to it. I think it's interesting that with all the sensors that people are now wearing because of activity and exercise, I think that helps things going forward for the public acceptability of wearable devices. I think down the road, maybe there may be a marriage of technology and the use of pharmaceuticals, for example, in terms of cost, maybe even prescription, because if one can cut their use of, say, an inhaler down by 50% because they've got advanced knowledge of inflammation, then that may offset the cost of the monitoring. It could even be, I could even see technology and pharmaceutical things being prescribed jointly. There's all kind of issues dealing with that, and regulatory and market, but that may be something we may see more of in the future.
But that gets back to motivation. I mean, people who buy Fitbits or people who are motivated to buy Fitbits,
and they don't need.
And they're well,
yes, I do.
Yeah, I would beg to differ. I would like to look like someone, but it gives. So if you've got diabetes with lots of cardiovascular outcomes, and you are insured in a way that more data won't necessarily injure your insurance, which is another issue we have to talk about, is how and who gets to use the data. is not a trivial issue. I mean, how many of you have health plans now that require you to either attest to not being a smoker or to agree to do smoking cessation, which I actually think that's a great thing, but you may disagree with that. And you take that a step further, and you're now, you'll get a much better healthcare rate if you wear this monitor that tells me how much nicotine you're taking in every day, despite how you filled out the form. I think we have to put in the psychology and the marketing and understanding what people use. But people who are motivated because they're scared to death that their kids are going to have an attack, they're scared that they're going to have an attack, or they've got elderly parents or relatives that are at risk for falls, and simple things like accelerometers to know whether someone's going to fall, and whether or not heat stress, which is a major issue for older populations. Those are all things we have to take into account. So it's interesting to advise and think about this. I personally would target populations that we could guess will be motivated from because they can perceive a benefit from knowing their environmental stuff, show proof of concept, and then move this into broader application once we show that it works in those who are motivated to use it. But that's just me talking much too long, I'm sure.
So I think that it's interesting. So one of the things that's coming out is that it's not the technological and the medical issues that may be the only important ones to deal with. There's also the social science and the economics of the whole ecosystem, if you will, that before you can really say this is the way to go. I wanted to see if questions from the audience, Stan?
So this is the perfect segue because I was sitting here listening to the discussion, and I spent 3 hours yesterday with a group of about 15 people from the School of Pharmacy talking about some new initiatives they're considering in the School of Pharmacy around precision pharmacotherapy. And a lot of it goes back to the dosing. And I was really struck by the fact that, and I'm throwing this out for comment, that a good part of what is possible is bookended by two things. One is what has been approved by the FDA. So you don't have an infinite number of doses. You only get maybe two choices or something like that. At the other end, how much ambiguity can the physician tolerate when they're looking at a patient? How can they assess how to create microdoses if they don't have all of the associated data? And I was really, I was struck by the thoughtfulness that the people who do pharmacological research have to put into the fact that you've got to get it through the regulatory process, and they also have to make it so it's a usable drug. So I'm just curious as to how. I mean, in essence, the environmental factors are drugs that are given without permission, and the dosage is whatever happens. So I don't know if there was a question in there, but I think all of these factors.
Any other questions from the audience here?
Just one comment. So, there's kind of a meta question here, and that is how to make the most rapid progress in this area rather than having everybody just kind of start from scratch over and over again. So the NSF Cyber Physical Systems program has supported something in San Diego called CitySense, where the Bill Griswold at the Jacobs School of Engineering has built personal air quality monitors that they claim anyway they weigh about 4 ounces. Couple it with Bluetooth to your phone, so you've got a phone and you've got a 4 ounce additional gadget that you carry around, and this thing is targeted particularly towards runners with asthma. And the idea is that they can collect their own kind of personal physiological data, right, as they're running. They're collecting air quality data as they're running. They're getting immediate feedback, right, which is the reason that they're willing to carry this stuff, right? So the miniaturization stuff, I mean, basically it requires you just implement it the right way. The technologies are there. And, there should be, appropriate niche markets, right, where people are motivated, to carry
So there's a circumstance where the unfortunate reality of physiology comes into play.
Yeah.
So that person out running in the ozone day, that day, his asthma attack's going to happen the next day. Okay. I mean, now there are other effects. Now, he may have an asthma attack because the relative humidity
Right,
is
he's
too
being
low.
told he's running in high ozone now.
If he's told he's running in high ozone now, there's actually two effects of ozone. One's a pain response. It's unrelated to asthma. Anyone can get that. And the other one's the asthma response, and not everyone gets the pain response either, which is the sensitive. But the point is that again, you have to target that, and the analytics have to. People need to know what they're going to actually anticipate. Sure. Now, if this is a person who runs every day, and they are preparing for a marathon on Sunday, having an asthma attack or two during the training may be something they wish to avoid. But oftentimes, at least in my sense, now, my public health colleagues may disagree with me, but
I don't want to argue about the details of it. I'm just saying there are existing projects, right, that have been making good progress. And the question is, how does one exhibit good scholarship to build on top of existing projects rather than kind of, what looks like starting from scratch over and over again, which is kind of what I'm hearing in this roundtable, right? How do how will real progress be made as a community?
Well, to me, this is a more philosophical answer than a technical answer. The funding models have to be such that people can get paid to collaborate.
Mm-hmm. Right. Okay.
Otherwise, if everyone's competing with, the absolute competitive model means that, I want my gizmo to work better than your gizmo, and even though they're the same, pretty similar gizmos. So unless there's a bigger goal that people are competitive but also collaborative, like the space program, going to the moon was a national goal. Lots of companies got made, but there was a general goal, and everyone kind of got there. Now, I'm not sure that personal monitoring has the same allure as getting to the moon, but I think that comes down to funding agencies finding clever ways to get people with similar products. And of course, the big prize is if you get a patent and strike it rich, so part of that is the whole team science and how do you get people to collaborate in a safe space that you can make that progress. And there's clever ways to attempt to do that, but mine's bigger than mine, and business people and legislators that are more active in that will actually make that happen.
So I think that there are plenty of problems to go around. I mean, when I got into doing this work with Andy, I was familiar that there were several groups who are building sensors, who are using sensors. You just have to look at the recent NIEHS conference that happened down in the Research Triangle, and they have a whole a PDF full of every sensor, every person who presented about sensors on different aspects of sensors. So I think the question that I ask myself before I get into this or put in a different grant is what hasn't been done, or what's the niche that I can feel, and the niche not in the sense that it's for a specific population, but what is the gap in the translational knowledge that I can fill? I'm not a computer scientist, I'm not an engineer, but I know public health and I know a little bit of data analytics. So how can I translate between those who are generating the data and those who are going to use the data? And that's how I have answered that question, so that I'm not building on top of other people's ongoing projects and leave that up to the experts.
I think we have probably time for one more question before you need to do the closing remarks.
No, this goes to 1:30.
Oh, of
So
course.
you've got time, and we might also have people on Webex who may want to jump in with their questions.
I thought it goes to one. Okay.
So maybe go to 1:15 for conversation,
Okay.
and then we'll
Okay.
close. So is there anyone on the line on Webex who would like to ask some questions?
There's nothing coming in through chat, but they may want to unmute and ask questions.
Yeah.
There's also some tweets, not really like a specific question, but we do have one person who said just kind of a comment that I think might be interesting, that it's still early days for environmental health exposome, and it says informatics lack of data standards. So I don't know if that might be an interesting segue. Does anybody on the panel want to comment about some of the issues related to standards in this?
Yeah, one thing I've been thinking about mentioning is the issue of standards and evolution of standards in technology. I mean, one of the challenges of all these disparate research groups producing one-of-a-kind devices, and we've done this ourselves, is, A, first of all, they become obsolete so quickly. But B, is there's hasn't been any standard methodology so that one can take, devices from this group, and this group, and put them together and use them. A lot of us have suffered through Bluetooth to the point of Bluetooth 4. Bluetooth 4 is just wonderful because now there are standards that are embedded in the chipsets that effectively, if people develop devices that use Bluetooth 4 chipsets, then they effectively build a device that has a communication standard. So one can, in an app or a platform like we've done, talk to new devices as they become available. There used to be, you had to go back to the drawing board, write new software, spend $25,000, interface to some sensor, 4 months later is no longer available. Now, that plug-and-play aspect, I think, is going to benefit more rapid adoption for mobile technology of environmental sensors, provided that people that develop it make use of those standards.
So you're talking technology standards and other technology.
And there are a whole list of standard communication, what they call characteristics of Bluetooth 4. It may behoove a group to start thinking about developing those standard so-called characteristics for environmental sensors. I don't think they exist, except for like temperature and humidity. But for other sensors, that would be a good thing.
You have a question?
I did. It was a bit different from the current stream of conversation. But so I currently do research in global health and international development. And in thinking about this, even in addressing health disparities, say within the U.S. South, how does something like this translate to low resource environments? How do we take the applications of the technological and data science innovations that we're talking about today, and then translate them into low resource environments, either at the community level or even at the individual patient client level? I'd just be interested in some thoughts about that.
So I'll take a stab at that. Although folks at the Ohio State University, they continue to wish to be known. I think that part of it is empowering some of these low, SES depressed areas to know what their exposures are. Some of that can be done by GIS, but part of that is if you know that your environment, whether it's your home environment, so if you live in a multifamily dwelling that's at low cost, which in the old days would be called a tenement apartment building, and you're trying to make a case that your environment is not conducive to health, and you get some kind of data. And frankly, whether the sensors are calibrated at the level where you could make regulatory change or on that, or whether or not it's a very simple device, even if it just raises the question that forces the appropriate people to make a more nuanced look, I think that can be very helpful. I think that oftentimes engaging the citizen scientists within the communities to be able to arm them with their own information, their own data can be helpful. And I think you don't need 24/7 monitoring. You need the occasional snapshot at specific times of the year so people can have that information. I can tell you I get asked not infrequently to write letters for patients demanding that their landlords strip up carpet and deal with humidity issues in the house and all that sort of thing, which actually my prescription pad doesn't really give me much authority to do that. It's like several titles, all of them put together might actually be one job description. But I think that part of it is that. Part of it is and I think that people who are expert at engaging communities need to help us understand how we engage communities so they see it as empowerment and not as intrusion.
As you had mentioned about.
So yeah, so I was going to add that there was a presentation, or there was a gathering a couple of weeks ago at the NASA Goddard Flight Center, where they brought together those who work with satellite data and air quality and health. And there was a presentation given by, the name of the person is Jason Jabour. He's a regional coordinator for the UNEP program, and he gave a talk about how they were using approximately $1,200–1,500 sensors in Africa to do some community outreach and education in those resource-poor environments. And so there was another talk by some of the UNICEF representatives and the World Bank even on using sensors. Interestingly, the conference was on satellite data, but it very quickly moved towards these sensor-based air quality monitors, and whether they're the same as the federal reference monitors or not. There were several folks from the EPA there. But that was an example, I think, where those who are working in international development are starting to see how these sensors can be used to build trust with the citizens in the outreach and the development projects that they're working on. First, to know what the exposure is and what the impacts are, but then to be actually able to do something about it. And I think citizen science plays a huge role in that aspect.
I'm gonna, yeah.
We have a Webex.
Okay, Webex question, Sarah. I'll get to you in a minute. Let's go to the Webex.
Several questions have come in through chat. First, is anyone doing work with FHIR and big data tech? If so, can you share what you're doing and any lessons learned?
So fire data.
Yeah. So FHIR is a data interchange standard, which is being touted as a replacement for what is being used in the hospitals now, which is HL7. I'm not sure that anybody here is actually involved.
I'm way unqualified to address that.
So Jim, this came up before around Odyssey and OMAP. I think fire was one of the. So when you're talking about environmental data, is there an evolving standard that everybody is looking toward? I'm picking on Jim because I know he's likely to know.
Well, I only know about some of the ontologies describing different kinds of environments. I feel like there's probably a lot more out there about related to sensors and GIS. But there's this INVO ontology that seems to be getting taken up into a lot of different efforts, like been using some of the biomedical ontologies, but also this United Nations like sustainability goals, or building something off of INVO ontology.
Could folks on the line hear that? Do we need to repeat it loudly?
Pretty good. Saurav, you had some comment, I'm sure. So
I had a question rather. In Dave Peden's opening comments, when you were describing your research in understanding air pollution effects on humans, I think I heard you say that there is a need for algorithmic approaches. And if you were to expand on that, I was trying to see what you meant. The domain we are looking at, there are three aspects of that. One is just characterizing air pollution, either using low-cost sensors or high-resolution equipment, or even multi-scale modeling. That's one part. And the second I can think of is actually the mechanistic effects of air pollution on human health. And the third is data analytics. Which area were you referring when you said there's a need for algorithmic approaches?
Well, what I meant by that, automated might be a better way to put it, but basically, individual physicians are not going, you provide exposure data in one screen and, patient, activities in another screen, and information about their pharmacy, buying habits in another screen. That no physician has time to do that. that simply will not happen. So there needs to be a automated, data-driven, whether it's algorithmic, if that's the right term, but there needs to be a way for those data to be able to be combined together, and it'll probably have to be addressed for specific diseases or individuals that have multiple diseases. We've not even talked about that. A lot of people have more than one disease. But that would need to be somewhat automated so that I need on my cell phone a text message saying the automated environmental health surveillance system has told me that Sally Johnson is about, it has a collusion of events. They probably wouldn't say collusion of events, but is at risk for this. At least to ping me to look into, have my staff call her. Is she okay? Look at the specifics of that. But it's going to need to have the data from all these things put together in a way that human beings can, that are charged with making clinical decisions, whether that's a physician or a nurse practitioner or a clinical social worker who's charged with some outcome, but somebody who's going to help that person and champion that will get a distilled cluster of information to make use of it. If these things remain in completely separate domains, it's going to be very difficult for health professionals to actually make actionable, to take action based on the data.
So you're thinking of the entire spectrum.
What?
You're thinking of the entire spectrum.
Yeah, and of course, part of this is new research. We're going to have a more nuanced understanding of how discrete day-to-day environmental changes are, and for some diseases it'll be very abrupt, and for others it may not be. But I think we're.
Kirk, you had a
I would
question?
just,
I was
going to add that I think a lot of times we think about bringing these different data streams together, these variables, and when I say that, my mind, or when someone says that, my mind right away goes to machine learning, because you can have so many variables to try to do that. And I think there is an appreciation now emerging within epidemiologists that they need to take a leading role in driving that conversation about how those different domains of data are coming together through algorithmic or automated approaches. And I don't think that's going to happen anytime soon, because we just don't have the tools or the training to be able to do that. I think our biostatistician colleagues can probably help a lot in that area, but even then, for them, their training doesn't really extend beyond what they have known from before. So I think that as in public health, we need to take a bigger role. Otherwise, we're going to end up, I fear, with a combination of different factors and weights and how the data is brought together. That's not going to be at the quality that clinicians would like.
Very good. We have
Webex.
that's right. So there's at least two questions on Webex, and Kirk had a question. So I'm going to start with Kirk before we go to the two Webex.
So, if you're going to have this much data and try to use that rationally to make decisions, it seems like you're suggesting that the role of physicians will change a lot. And in fact, it may not be anything like it is today. I could imagine if in the world you're describing, that physicians more become epidemiologists than diagnosticians at a personal level. What do you think will happen when we have all this instrumentation?
Well, first of all, I agree with you that what physicians do will change, but I'm not sure of exactly how that will change. But I do think that the ability to reckon with different data, to be able to not feel, to be able to take algorithmic data and apply that to individuals. And I also don't think that this, that we're going to get to a point where everyone's going to be out, where precision medicine is going to be so data-driven that individual physicians talking with actual people is going to be eliminated. But I do think that the ability to deal with data, to take data cues, and we are a couple decades away from this, at least from this being refined to the point where you can put your position on entire autopilot. I mean, even right now, when you fly from Los Angeles to San Francisco, or well, make it a longer flight, Los Angeles to New York, much of that flight's probably on autopilot, but there still are pilots in the front seat, so that when things happen, you can address that. And I think that that's going to happen. But I also think there's going to be system-wide healthcare decisions that these data can help impact as well. If all your congestive heart failure patients, you find out that they're from a couple different kinds of communities, either specific communities or communities with certain environmental patterns, you may find that, again, this gets back to the remedy for those people may not be more Lasix or another pressor or more medication. It may be that they need a cleaner house. And ultimately, helping them move to a cleaner house may actually cost the insurance company less than more medication. And if you say, for an asthmatic, this calculation we do now with the $20,000 a year biologic therapies for asthma versus how many ER visits do you prevent with that before that's a wash. And I think the data is you're going to end up making some of those kind of calculations and how the data is employed. You may find that helping people live in cleaner environments or doing zoning laws such that you stay away from certain zoning areas. Houses aren't built within a certain area. Of course, then when we talked about that, another issue is that realtors may not like that because they, suddenly if your house value is less because you find out that you live in a high polluted area and no one wants to live there, you're trying to sell that house, that would be really inconvenient.
Question came in on chat. I wonder if establishment of common schemas for the data collected so that both immediate and future use of the data is facilitated. For example, a common core schema. What do you think?
Well, I mean, that's certainly a good objective. To get to, I mean, you have these ontologies that Jim's familiar with for structuring information, ways of relating environmental data to the related health effects and health record, I think are really important. And there are a number of schemas out there for collecting research quality data and health data. And then there's technologies like Bluetooth for helping to interface to that. It just has to be tied together.
So, Ayaz, do you know anything about environment, about standards for environmental data?
Yeah, so I've been involved in a project that's been trying to do something similar for food environment. And, when I speak with so they're calling it the Internet of Foods. It's a group at UC Davis that's running this initiative. And when I talk to them about, okay, you have all this data about, food and where it's coming from and who manufactured it and the processing, and you have all this information, how are people actually going to use it? And so there are usually startups that say, well, the refrigerator can tell you what you're eating and you can be more sustainable, you can be more economical, and so on. But I think the health linkage is still missing. I don't know how ontologies can help us relate environmental factors to health. I just don't know. What I get from it is that we can automate a lot of things, and that's really why we want ontologies, so that computers can take in this data and spit out a classification or make sense of these data. So we're creating those dictionary algorithms. But from a public health perspective, I don't see why we need ontologies or where it's headed. I mean, we have land use maps, so those are categorized. And so I think ontologies are only helpful in cataloging the data, but I don't think we should think that we can automate how those data will be used to link with health outcomes.
Yeah. So I'm not sure exactly what the person asking the question had in mind, but perhaps maybe they were talking about ontologies and standards for environmental data in the sense of being able to compare and contrast different ways of collecting the same environmental data or being able to use them in a collective as opposed to being completely non-comparable.
Yeah, I mean, so that's fine. So there's a Canadian initiative called it's called Canadian National Environmental Health Signature Initiative, and what they're doing is they're bringing data from all over Canada, from all types of environmental exposures together. So they're bringing in the air pollution, the noise, the pollen, the land use, the built environment, all of that. And so I think ontologies are great to help us bring that data together. But I don't think for environmental health it's going to be that useful, because the way we compare exposures and their effects on health through dose response curves and things like that, I think that's where we need the environmental epidemiologists to step in and use the tools they currently have.
So, Ayaz, I want to I don't want to push back, but I want to ask a question. And I admit this question is formulated out of naivete and a lack of complete understanding of either chemistry or biology. In fact, I shouldn't say lack of complete, I should say lack of almost any understanding of biology or chemistry. But to me, everybody in the room here laughed when you said Internet of Foods, but then as soon as I think about it, if the cottage cheese QR code was scanned by a sensor, and that could be fed into an assessment of my microbiome, soon I begin to look at the environment as the biggie, everything that affects, impacts me. And so then suddenly the ontologies start to take on a whole different life, because we want to link into very disparate data sources in order to understand how your genomic information and how much water you drank yesterday and whether or not the cottage cheese was from pasteurized milk or not. And I could go on and on. Every part of this is part of the living system. But now that's downstream, I admit, but I also argue that doing some of that work earlier rather than later, even if you do it poorly and have to reiterate 4 times for Bluetooth, is a good idea, because then you get this platform effect. Does that make sense?
So that's what I was hearing, is that if people wanted to know about the effect of the microbiome on their environment, and they have specific diseases that they're concerned with. So we had a physician present at that conference, and she said, I measure everything about every patient who comes to me. I do all of their genetics, I do all of their microbiome, I do everything on them. And I think if you do that, then you can create those relationships of what that QR code and the ontologies the data that it contains, and the relationship between those different types of data. I mean, what's the relationship between your microbiome and your genetic makeup and your family background and your where you grew up and what your poverty level was and your food insecurity? And I mean, we don't know what those relationships are. We know barely, very little of those relationships to actually feed in and take in that QR code information. And that's what I worry, is that we're basing these decisions on data that we haven't first collected, and relationships that are very iffy to begin with. And I think if you want to read more about that, there was a recent JAMA discussion on precision medicine initiative arguing about population and individual level issues. So that's where I'm coming from, is that I think it's well-intentioned, but I don't think we're there yet.
Thank you. I was nodding my head.
You got
up here, and you guys can hear me. This is Renata, the other co-executive director for the South Hub, and I just wanted to chime in about the precision medicine. My background is in genomics and precision medicine, and I 100% agree that we're not there yet with making the types of connections with microbiome. So I just wonder if there are some startups that are doing this connections, and at the doctor level, it may be very unfeasible because you really still have research that needs to be done, and then data storage issues with keeping all of that information. So I'd love to know how she's doing that position. But there's specifically a data science startup where they're doing that for a large cohort of patients around a particular disease, keeping their microbiome, their genetic information, their medical history, all of this longitudinal studies. And they're starting to find all of these connections and major pathways that they didn't know were involved for drug development. They started it for drug development. So they may have the beginning of something in certain specific disease states and for looking at interactions across pathways that could translate into more actionable information around personalized medicine and connecting some of those dots in a way where each physician the burden isn't on them to make all of the connections themselves.
I don't think individual physicians are going to be able to do that. That's simply not going to be. That's what I was getting at with the question about algorithmic, automated ways to commingle data. And I completely agree that there are both very promising observations about microbiome and genomics and epigenetics and any number of specific factors, and certain patterns are evolving in asthma is probably one of the biggest populations outside of cancer biology where this kind of stuff is being looked at. And there's some very promising stuff, but I also agree if it were a drug, it would be preclinical. It wouldn't even be phase 1 yet, some of the data. Having said that, I do think there are relatively simple measures. And when I go back to the engineers I work with in the device thing, and people start imagining all kinds of things you could get, and I said, if you could just simply give me reliable pulse, temperature, blood pressure, and like real basic stuff, in a device that's smaller than a dime that I could wear unobtrusively, and it would transmit reliable data. I don't need an EEG. I don't need. Although it'd be cool to have the thing on Star Trek that I could wave in front of somebody and get a diagnosis. But a small number of simple measures done reliably everywhere may be the first step versus all the whiz-bang developing things that are going to come on top of that. And then marrying that with a couple of very basic, for all the environmental factors, the environmental factor that kills people a lot is heat stress. The person who's going to play offensive tackle doing 2-a-days in the summer, when they fall out, that's because they're dehydrated, and that's because they got themselves in that condition. So there's some very straightforward ways where the measures may not be complicated, but the technology and the analytics to take a small number of focused bits of information, put them together in a clinically relevant way, could be a very important place to start. And also, not everything has to be FDA approved in order to be useful, or else no one would be wearing Fitbits.
I think we are at the last 2 questions. Yeah. There's one on Webex, so Carl, you want to read that out?
A question came in on chat. How do you account for or deal with data uncertainty?
Ayaz or Andy, do you want to jump in?
Yeah, this is a question that keeps me up at night because this really is a good question, and I think that the simple answer, the short answer, and then maybe Andy can answer as well, is that you do the best. You be upfront about it. You be transparent about the uncertainty in your exposure assessment, and then how that trickles down into your health effect estimate. And I think if we can do a better job of simply communicating that we do have uncertainty, and these are the multitude of ways that we can quantify that uncertainty and be upfront about it in our publications, then I think that's the first step.
Thank you. I'll go to the, so I can get your question in.
Okay, thanks. Becky Boyles from RTI. I just want to add, I've been working in environmental health science and some of that in regulatory agency for a long time. And I'm feeling like there's a sea change where it used to be that a lot of environmental health research, the audience was really the regulators, And I'm kind of feeling like in the last couple of years that there's a dramatic shift to the audience now being more public and viewing the public as consumers. And I just want you to comment on that, because I'm actually kind of seeing that across the board in EPA's. Even though they've been talking about citizen science for well over a decade, they've now said that they're going to integrate it into all of their strategic goals within the agency. So I think we're seeing this percolate through. And just wondering if you guys could comment on that and how you see that affecting research going forward.
Well,
David?
Well, being over loquacious again, that I work a lot with EPA, and you're absolutely right. Over the past 5 years, and frankly over the past 2 years, it's been very clear that much of the lowering the national ambient air quality standard or changing it for a given pollutant. With the most recent change in ozone, I think even before the election was clear, it was very clear that they were moving towards citizen science. They were moving towards a public health mission more so than a regulatory mission. Because I think that the level now is at the point where many states, many of the people at various state levels that were charged with maintaining, we're close enough. It's hard for me to say what else we would do to get lower. So I think that they moved their mission towards susceptible populations, going to communities, identifying people who are at risk, and more. If it's going to be regulatory, more focused regulation, like zoning, so your house is away from a roadway, and looking at those sorts of things versus targeting, lowering the ozone standard more. And I think that, I think the EPA has been moving that shift. I think that as business interests have responded to that, that's going to be a continued thrust of environmental research, is how do you take all this data and make it actionable for individuals and communities to deal with, as opposed to, top-down regulations can be more at the community level.
Thank you. Do you want to wrap up?
Well, so do anybody in the panel have some last statements about... So as we close, does anyone on the panel have some last statements about priority research challenges we see going forward?
I thought Dave's summary was a good one.
Okay.
Get a few sensors that work well and see if you can fit them into the clinic. Like the camel nose under the tent.
Well, and beyond that, in terms of whether it's because of course all of us are going to say our research is the ones that needs to be prioritized. I certainly will, as I do in every grant application. But I think if we're going to go from sensors and environmental data to health, I think how we interface with the electronic medical records system and how we engage healthcare systems, because at the end of the day, physicians will do what compensates them. I mean, they do it because they want to help people, but their mechanism is going to do that. So physicians are going to spend very little time incorporating environmental data into the day-to-day work if there's no way that preventing environmental injury is going to result in not getting pressure to do that. So I think we have to engage healthcare systems as that payment system continues to go from a population-based care to individual RVU-driven care. That's where we'll see that. So some of the research is going to be at a business economic level as much as it's going to, that's going to drive where the scientific research can be best applied.
Andy or Ayaz, are you still on the line? If you have any last thoughts?
Yeah, no, I would just echo. I think David's absolutely correct. A lot of the healthcare financing models are actually incentivizing community partnerships to do exactly that. And I think the time is now to use these sensors. They're cost effective. What they're measuring may not be absolutely the best, but I think for the purposes of showing which areas to avoid and sending cues to doctors, I think that's the way to go. And I think what we need also is greater education, probably within the medical schools and the public health schools, on appreciating the use of algorithms and working with engineers. Obviously, my experience with Andy has been really fruitful. I've learned a lot, and I think we need more of this going forward.
Excellent.
Ayaz, Andy, Dave, and
Yeah, so we want to thank the panelists, but before we let folks go, we want to let you know that the South Big Data Hub's Smart and Connected Cities Communities community call will be this Friday, the 13th at noon. We have Cora Rademacher from UNC Chapel Hill talking about the North Carolina Smart and Connected Communities Initiative. We have Iris Tien from Georgia Institute of Technology talking about integrating data across sources to detect disasters and critical infrastructure failure events. You can email myself or Stephanie or Renata Rawlings-Goss to get more information about that. Also, the next Data Science Roundtable for the South Big Data Hub will be Wednesday, February 15th. We do this monthly from noon to 1:30 Eastern. It'll feature a panel on the Rare Disease Observatory. And I think we have the website up here that you can go to get more information about that. Also keep an eye out for Hold the Date that will be coming soon for the South Big Data All Hands meeting. And we'll be having a smaller meeting on mobile health in May to follow on to the discussions of these roundtables. So with that, I would like to thank the panelists and Stephanie and Carl who have helped with logistics, and Ashok who's moderated the meeting. Thank you very much.